Okay, great. I'm Dr. Gimpel, as you heard. I'm originally from Argentina. I'm a family physician. I work with the underserved. I also teach in medical school. And I have this kind of weird accent because I speak Spanish. And so if you get lost in some of the words, please raise your hand and ask me questions, please. So the objectives of this talk is going to be present an overview of the healthcare disparities. We're going to talk a little bit about social determinants of health. We're going to talk about the oral, health disparities. And I'm going to share with you some of the experiences that we had in response to those disparities in medical school. Is that okay? So back in 2000, the JAMA journal published this graph that you see on the left. The idea was to explore, the causes of death in the United States. And those causes were called preventable causes of death. As you can see, smoking seems to be the highest there. So people start talking about, well, what's wrong with we need to work on behavioral changes. Well, this article was, very important for all of us to continue working on prevention. But then, almost 10 years later, 2009, the group of people in Harvard School of Public Health did kind of a similar assessment. They look at preventable causes of death, and I want you to see that smoking seems to be still the same problem, and the highest, followed by hypertension. The point of this is that we are talking about preventable causes of death, and the point is, what do we do for prevention? This is a model, the county health ranking model created this graphic to show you, what are the main components when we talk about health outcomes. And you see, physical environment, social and economic factors, clinical care, and health behaviors. When I talked about smoking, I was, mainly talking about health behavior change. But clinical care, which is one of the issues that we're going to talk today, it counts only for 20%. So what are we doing with the health behaviors? This is the role, our role as physicians, as dentists. So before we talk about prevention and before we talk about what do we do with those things, I would like to talk about social determinants of health. And what are those? And who is responsible for those? The social determinants of health are sort of the context where the individual lives, are the resources that individual have, are the things related to the neighborhood, the community resources, the opportunities that individual will have. And that goes beyond any genetic endowment. So to graphically show you this, we have the individuals in the middle, and any of the things that you see, related to education, work environment, working conditions, unemployment, housing, are all those social determinants of health. So when we go back to this model, the social and economic factors are, as you can see, 40% are, related to the health outcomes. And those are the socioeconomic factors that I just mentioned: housing, work conditions, physical environment, where people live, where people work, the conditions that they live and they work. Education is part of that. Access to food. We encounter this in Dallas pretty often, healthy foods in grocery stores. Ways that people can exercise and be safe when they exercise. Fast food, crime, are all those related to health behaviors. But providers, we are in only 20% of this, graph. That means health to access, and that means quality of care. So I think that we have a lot of work to do in the other components that are not just, our visit in the clinic, in the office. We want to talk also about the health disparities, which is not the same that social determinants of health. The term health disparities refers to the difference in health outcomes between groups of people. And that is a deficient, that is a lack of efficiency from our system. If we encounter disparities, that means that something is not working right. And health inequities are not the same as health disparities. Health inequities is the difference in health outcomes, but between groups that have kind of the same, preventable, opportunity. And if we encounter inequities one more time, we are doing something wrong. Examples of health disparities are cancer being the second leading cause of death. African American men are more than twice as likely to die of prostate cancer when we compare this to whites. Hispanic women are 1.5 more likely to be diagnosed with cervical cancer. African Americans, American Indians, Alaskan Natives are twice likely to have diabetes when we compare with whites. And the same thing occurs with Hispanics. Something is not right. Why do we have those disparities? I searched a little bit more about oral health disparities. I'm familiar with, what we do in the medical, school, in the medical field about health disparities, but I searched a little bit more about oral health disparities, and you probably know about that even more than me. We do know that there are certain ethnicities, certain groups that are suffering for really poor oral health. And we do know about children and tooth decay, and which are the groups that are suffering more. We see, the Mexican American and blacks and non-Hispanics are, the ones leading that disparity. In terms of adults, we see the same thing. African American, Hispanics, and Mexican Americans are at the top for young adults. And tooth decay and education, when we look at health disparities, we see definitely that less educated people that had not an opportunity to finish high school education, experience more, the untreated tooth decay. Adult and oral cancer. We also see that the rate of, survival rate in adults is lower among blacks when we compare with whites. So where are we going? Where is the vision of what do we need to change? Where do we want to be? Years ago, the HRSA, and I know that this is, actually funded by HRSA, and then the California healthcare system, and asked the Institute of Medicine to convene a committee to address those issues, to talk about what do we need to do to work on disparities in oral health. So the vision was that oral health should be incorporated, and this is not new for all of us, should be incorporated in the overall health of an individual. And the statement, that leads that report is good health requires good oral health. And promotion and disease prevention, were the essential component of that, discussion. And that was, the Institute of Medicine trying to come up, that was in 2009, trying to come up with where are we going with a plan on how to address disparities. But in a more broader way, the nation is looking at the same thing, oral disparities, through Healthy People 2020. I don't know how many of you are familiar with the Healthy People 2020 document. There are more than 600 specific objectives for the nation, and with specific measurements on where do we need to go and how we all working together can accomplish those outcomes. And the main focus has been on preventable disease, quality of care, eliminate disparities, promote quality of life. And let me tell you that I reviewed also the Healthy People 2010. And it's very interesting. I was presenting this to medical students recently, and Healthy People 2010 had very similar objectives. Then again, 10 years later, we are talking about Healthy People 2020, and then repeating the same thing because we were not able to accomplish not even half of those outcomes. So once again, there is something that we need to do together. And 17 of those Healthy People 2020 objectives are related to oral health. And some that are not exactly oral health are related to chronic illnesses that, of course, diabetes or cancer, that of course have a relationship with oral health. I want to show you how that document looks like. So if you're interested in looking at it, you will find what maybe is interested for you. So the way that, so if you search, Healthy People 2010, you're going to find, in this case, I specifically search for oral health. And that's the way that the document shows, what should we do about, reduce the proportion of children and adolescents who have dental cavities experiencing their primary and permanent teeth. Those are specific health outcomes, and the same thing with adults, and how to work on preventive services. And the idea of each of those is to have a particular outcome. So you can have a more detail on what is the target? Where should we go? So the idea of reducing the proportion of people with, the little ones with cavities will be to reduce at least, the target is 30, to accomplish 30%. So the programs that we have to implement should respond to that need. But in a more broader way, not just the kids that we see in our clinic, the kids that we see in the community. We'll see 10 years later when we get the Healthy People 2030 if what we have accomplished. But it is kind of frustrated to see that sometimes seeing people working on totally isolated programs are not looking at a main goal like this one and working together. So what are the main barriers to getting good oral health care? The ADA published this recently, or had that at least available for everybody, to identify what should we do and what are the main obstacles. It seems to be the coverage, one of those. People, the kids in Medicaid and in the special program in CHIP, supposed to have access to it, but that's not really available for everybody. It's not all the programs have the same opportunity for everybody that is in Medicaid and CHIP. And adult coverage seems to be one of the main barriers, and that's not definitely new for dental care. But that's not only about the money and the coverage. One of the things that the ADA, of course, identify is that it's about public programs and not working on education and promotion and prevention. Too many Americans don't have the basic understanding of oral care and brushing and flossing. And the water, if we have fluoride in all, the supplies in all our water systems seems to be an issue too. And this is very, is related to underserved populations, but because of the disparities, we see it more often in populations that are suffering. But it's not only, the lack of education is not only among those groups. So now I want to talk a little bit about prevention, and I'm going to use the cliff analogy. I don't know how many of you are familiar with this. Will, are you? No, familiar with it. The cliff analogy is something that Camera Jones created. I think she published this article in 2009 or 10, and he's using the cliff analogy to better explain where should we invest in our health system. And it is a good analogy to explain, the different levels of prevention and what should we do about it. So let's assume that this is someone that is going to fall from good health, okay? Is approaching the cliff and is gonna really, fall off the cliff. We can put an ambulance there, and that ambulance will help, that person to, take it back to the health system or assess the injuries. We can put, a net in the middle, and we can try to prevent that person to fall, right? But the net has some holes there. And so people fall through the cracks too. We can put a trampoline there so that the person will go back. We can put a ladder so the person go back to good health. We can put a fence, and if we put a fence, the person, when it's approaching the cliff, might stop. We have not only one individual, we have families, we have communities. So the ambulance represents the tertiary prevention. When the disease already occurred, when we have to work on reestablishing, good health, the net, trampoline, or ladder represents a secondary prevention, which is when, to do early detection of preventable diseases, and the fence represents primary prevention before, something occurs. So we have families, we have communities, but before the fence, we have those social determinants of health that I talked at the beginning that are related to the context of where the individual lives, that are even before that person reach the fence. So if we work only on the levels of prevention, we are missing a big component, that we can work with this family and this community, addressing, how people live, the access to a good place to work, exercise, access to good food, access to education. So let's stop for a second and then think about the cliff. Again, the cliff analogy, but expanded a little bit more. So we have the ambulance, tertiary prevention. We have the net or the trampoline or the ladder, and then we have the fence. But we have different people, exposed to this kind of system. But we not only have different, people that are trying to, or going or approaching the cliff, we have differences between those groups. And that's what, of course, I intended to represent with different colors. We have different cliffs, and we have different points that people can fall off the cliff. So it is in different dimensions, if you want to see this in 3 dimensions. But we also have problems with the system. So the ambulance, I'll go back so that you don't miss it, so it had a flat tire. So the ambulance is not responding well. We had a non-responding, tertiary prevention. And that happens in many communities. We don't have hospitals, right? And we don't have access to, the tertiary prevention, which is treating people that already have had not only exposed, but have the disease. We also have many communities that we don't definitely have tertiary prevention, but we don't even have access to secondary prevention to detect diseases before they occur. And we have, fences that are not really working. Not only that, we have people that those social determinants of health let me go back, we have inequities. So those social determinants of health are not the same for everybody. So people are closer to the cliff Some people, some groups are closer to the cliff than others. So we have people exposed to different opportunities, different resources. We have differences in quality of care. We have differences to access care. And we can try to assess and address those issues before people are approaching the cliff, and making sure that everybody will have the same opportunity. And that means working on assessing and addressing social determinants of health. All the things that I just mentioned that are part of the context where individual and community lives. The factors if people can make good decisions, and the factors that they are exposed. So, any questions so far? Yes? No? So let me tell you now what we are trying to do in medical school, and I'm sure what I've been doing to sort of work on the things that I described earlier. So for us, it's important to think that everything starts before people come to the doctor's office. And the main reason for that is because I just spoke about social determinants of health. I just spoke about social disparities. So I should not start when people come to the office. I should start before. And I should start working with trying to change and collaborate with those communities that will like to work on changing people opportunities. So if everybody has the same opportunity, then they will be exposed to the same sort of factors. If they don't, then we see more inequities. In the medical school training, we ask the medical students when they finish medical school to respond to this questionnaire. I don't know if, do you have the same thing here? When they finish school, in dentistry, it's kind of a survey to ask, how was your education? So I compiled the information from 2009 to 2013. We'll see what happened, this year. And we found that, there is a significant percentage of students that graduate that felt that in some areas they didn't receive good education. And especially in the areas of health disparities, in the areas of addressing social determinants of health, and culturally appropriate, ways to treat, certain populations, and especially in the areas of community medicine. And this is not just UT Southwestern, so it's not that they are just talking about my community's medicine stuff. But I'm just kidding. The thing is that we asked them how they feel about their training, and I'm bringing this because I think in one way that we can start to work on social determinants of health and social disparities is to think about what are we doing to train people. And what are we doing to, get those people aware? Those important things, and this is the reason probably why we are here today, but what are we doing with people in training that are going to be part of that community, that are going to be working on Healthy People 2030? So based on those results, based on the questionnaire, we definitely identify a need. There is a need for more innovative approaches to respond to, how we train people to better understand the health needs of communities. One way that we found that we have implemented is something that is called community-based research, and I've been doing that for several years, and now I'm doing it more to train, students and family medicine residents on how to conduct community-based research. And the main objective of that is to work, in collaboration with people in the community to better train our future physicians, but also work with the community to respond to that need and collaborate. So participatory, models of research, when you combine a community partner with an entity and work together to respond and answer a particular question. And it seems that family physicians or primary care doctors seems to be kind of the ideal candidates, because we do work, with the communities, and we are kind of the gatekeepers of the system. So the new statement that we are hearing more and more is that we should go where the patients are, not expect that the patients are going to come to us. And we do need to work not at the individual level, but we need to work at the community level. And that's what we are trying to do with our medical students and our family medicine residents. This is a way that we found so far that UT Southwestern has been responding to the increase in health disparities that we see, at least in the Dallas area. And CBPR, or community-based participatory research, and in particular, our group partners with around 30 different organizations in the community, schools, churches, community centers, charity clinics, that we work together. And I'll tell you more about how we do it. But we identify that need, and when we start working with residents in training, we think that it's okay that they are getting some of that education, but we realize that it's kind of too late, that we need to start really early, and that means medical school. We need to start with people are not even in clinical rotations, that they can even have more time to spend in the community. So we created what we call a pipeline, and integrate students and residents together to improve health disparities and respond and reduce the health outcomes. So what we do is mainly through partnership. We incorporate research. We incorporate what we call service learning. So this is not about volunteer experiences. This is not about going to a trip abroad or going to a free clinic and provide services. We encourage medical students and residents to do that, but under supervision. So that becomes a service learning opportunity. I'm doing something for this group, but I'm also learning. And of course we encourage research and publication to have a good understanding of methodology and research. So this is description of the pipeline. We start, and I apologize for the acronyms, but I know that you use a lot too. So the first box in the left side represents a medical student program that we have called CARD, Community Action Research Track. And students, when they enter medical school, they can, if they think that this is what they want to do, they want to spend more time doing community medicine activities, if they want to work on a project in the community, and they want to do more research, they can enroll into this program. And the program is a longitudinal experience, so they have different experiences through the 4 years that they're in medical school. When we created this, and by the way, it was funded by HRSA at the beginning, what we did is we created the program based on some required experiences that students have already in the medical school, and we created new ones that we thought that will provide, the principles of, population medicine, health promotion and disease prevention, CBPR, and provide that training over the 4 years of medical school. I think currently we have 50 students or 53 students enrolled in the program. We have been doing this since 2007 or so, and And the students that, many of those students ended up going to a MPH, and Master's in Public Health. Many of those students ended up doing a fellowship afterwards to work in the community. And the ones that recognize that they want to do a little bit more, they have the opportunity between the first and the second year to participate in something that we call Community Health Fellowship Program, which is the little box on the left side. In the CAR program, a subset of those students can decide to spend a summer with us, which is this coming summer, and work with a community organization. And in 9 weeks, they have to finish a project. The way that we do that is we don't go to the community and said, this is what you have to do. We have the community member and the faculty students in our group discuss what that community member needs. And if let's say that they need to do something about the people with diabetes that are coming to their clinic, then we try to formulate a question to answer specific that, and something that is doable in 9 weeks. And most of those projects are kind of pilot studies that are a foundation for bigger projects. Then if medical students at UT Southwestern are interested in family medicine, then let's say that they ended up going to our family medicine program, we offer them more continuity of what they have already initiated during medical school, which is another program called CARE, Community Action Research Experience, and that provides a particular track for the residents to work on community-based research. And one more time, they partner with a community organization, and they develop a program. But that is a little bit more longitudinal because they can start in a second year of residency and finish in the third year. This is a different level of the medical school, the medical students. The expectation is that definitely they're going to finish with publication. It's not that medical students don't do that, but the expectation with more clinical experience is to accomplish a good research project. And they sometimes write small grants to work on those projects. And then as the last step on the pipeline, we offer a fellowship, which is, a postdoc fellowship, to work 50% in a clinical setting and 50% in community. And that person usually works in CBPR, but also works serving in many of the sites that we have in the community. So that has been my experience, and I noticed that many of the things that we incorporated definitely are not innovative. Many other people are doing it, but it has been working well for the people that we have trained. And the ultimate goal is to see many of those physicians working in the community, in the underserved, and have them very well prepared and improve their skills to work with specific populations. In regards to overcoming the barriers in oral health, there is a national call. It was published recently to how we're going to do kind of the same thing. Promotion and prevention in oral health. There were the national call identifies 5 points, and starting from changing, the perception for oral health, and that means incorporating the oral health into the overall health. And going back to the Institute of Medicine report that I just mentioned, how to work or increase oral health workforce diversity and capacity, how to work with other groups and a more interdisciplinary work, and how to increase collaboration. One more time, when the Institute of Medicine says good health requires good oral health, talks about not only integrating oral health into the overall health, but also create ways to do that by changing, of course, the policymakers are having a role here, changing some of the regulations. They talked about why the supervision and the scope of services varies so much depending on the states, and why we don't collaborate and we do it all the same way. How we can improve dental health education and training, and maybe incorporate in more innovative ways, and how to reduce those, the financial burden that seems to be the barrier. But as I mentioned earlier, it's not about the coverage. I mean, we should think about also, transportation for people that are not getting access to, oral health, and that's not because of the coverage. It's because we have to look at the social determinants of health, where people live, and promote research, and expand capacity in terms of interdisciplinary work. One of the programs that I found that, and I don't know if any of you is working on this, that seems to respond to more the community-based research, is the school-based silent program, and going to the schools. We, in going to the school to identify the groups that might benefit for this, and one more time, going to the schools, not having the kids come into the office. And the other program is to incorporate and train more, physicians and not only physicians, but health professions in general, to early identify the oral health problems, and have a good referral system. We have in one of our clinics, we have dentists come in to just do the fluoride and teach, our, nurses and our residents on how to apply the fluoride. So there are many different ways to incorporate and work more in an interdisciplinary way, and go to the community. And I think that's it, unless you have questions. I just left a few minutes.